Thank you very much for asking me to come and talk about this subject. It's absolutely fascinating. I've been enthralled and educated, strongly educated by what I've heard today, and I hope I can contribute as well as the other people have. I'd like to start with a story, and it goes back to 1991, and my boss then, who was head of the unit, was Georgina Vagani. I don't know if any of you know or remember Georgina from Milan. And she was telling us one day of a patient she had seen. In fact, it was at the liver histology meeting that she was telling us about this. A boy of about 17 years of age who lived alone in Edgware in London, of Arabic origin, and who spent all his days watching the television, and ate takeaways which were delivered to his door regularly. And he was found, I can't remember by what mechanism, to have abnormal liver tests, and was brought in to be investigated by Georgina. And we were at the histology, and we saw a liver biopsy which looked like alcoholic liver disease. And we were perplexed by that because he was Arabic origin, and we were pretty certain he wasn't drinking alcohol. And somebody reminded us that already the adult services were seeing large numbers or beginning to see numbers of adults who are presenting with alcoholic liver disease, but said that they didn't drink alcohol. And despite the skepticism of doctors in the UK, which is, I think, fairly universal over that issue, it was accepted, and it was accepted, beginning to be accepted internationally, that there were patients who had liver disease that looked just like alcoholic liver disease, but wasn't. And the title non-alcoholic liver disease and NASH were beginning to be used. And we were initially astounded and then fascinated by this concept. We'd never seen anything like this before. However, subsequently, we have now got to a situation where, does this work? Yes. We're in a situation where we've had a series of audits over the last 2015, 2016, and 2018, and you can see we had 50 patients, 66 patients, and latterly 118 patients referred in. And so you can see that we are experiencing an epidemic, and it's simultaneous with what appears to be an epidemic of obesity in children in the UK. Now, these are UK NHS data from children aged 10 and 11, male and female, but you can see that this is rising more or less pari passu with our scanty data. I don't know what happened in here, but my suspicion, from having been there at the time, that it was something like this. And the age of those patients typically, referred to us at least, is of the order of 11 to 17. Of course, the cutoff here is probably because they don't come to us. I'm not suggesting that there's a direct relationship, but I think there's a strong indirect relationship. Obviously, they've got to be seen by somebody else, recognized, referred to us, and the mechanisms by which they come, I think I will surely come to. So, by 2030, as many of you have already recognized, the world population of obese children and adolescents will be 250 million. And they're growing rapidly. There'll be many more obese children in China, many more in India, and millions in the US. In the UK, we have 1.3 million obese children and adolescents by 2030. And I think our rate of growth is probably going to be a bit less than the developing world, but still we have an epidemic. And my concern is that the governments are not doing much or anything at all. And that can certainly be said in the UK. And I think there is a resistance to intervening against commercial interests. We have a sugar tax on fizzy drinks since April 2018, and I hope that that will have an effect. But nevertheless, I think more needs to be done. And it's true that this is a function of what we eat and how much of it we eat. And this has been made possible by a food industry, which makes cheap food in bulk. It's better that people don't starve, but nevertheless, this is a side effect of the consequence. Everybody today has provided a map of their world view of the development of obesity. This is mine. from 2016, boys on the left, girls on the right, and green is 5% or less. But you can see that in Europe, for boys worse, of course, we're up around the 20% and going over 30% in the dark red over here. Now, the definition of non-alcoholic fatty liver disease versus NASH has been mentioned already, but we have on the one hand simple steatosis and steatohepatitis with fibrosis, and the natural history has been touched on already, is that steatosis progresses to NASH some of the time. This is my representation of the natural history of non-alcoholic fatty liver disease. I don't want to dwell on it because I think it's been done better than this already today, but nevertheless, the concept is that fatty liver progresses variably towards cirrhosis, either perhaps directly, but usually by way of a steatohepatitis process, which progresses at about average of 7 years to progress by one fibrosis stage. A proportion, but it's not the majority, can regress back from fibrosis to non-alcoholic fatty liver disease, and non-alcoholic fatty liver disease, of course, can get better depending on the environmental circumstances. A proportion, perhaps 1 to 3%, will develop hepatocellular carcinoma per year once they have cirrhosis. But it's also possible to progress, as we've heard, rarely, but it does happen, from non-cirrhotic fatty liver disease to hepatocellular carcinoma. I put this in because I think this is, to some extent, the bottom line of where an epidemic might go. This is 2 studies, but actually they overlap because they use some of the same UNOS patients. 330 adults and children and young people who underwent liver transplantation for non-alcoholic fatty liver disease, which really means, I think, for the most part, cirrhosis decompensated related to NAFLD or NASH. 14 of them were under 18, so they were genuinely pediatric patients, but another 20 were young people and presumably had had the condition since childhood. The median follow-up was just less than 4 years. Overall, the mortality associated with transplantation is 30%, and I'd remind you now that the expected mortality of liver transplantation is less than 5% now. So these don't do well, and 11% during this 4 years ended up being retransplanted, and similarly, that's a very bad rate of need for retransplantation. And about less than half of those, but nearly half of those, got NASH again. The outcome of retransplant is worse for NASH cirrhosis than other liver diseases, and the complications of immunosuppression, like tacrolimus, steroids, sirolimus, look very similar to non-alcoholic fatty liver disease. And the body composition of patients after transplant is much more like fatty liver disease, those with fatty liver disease, than the rest of the population. So this is, if we're thinking of transplantation as being a solution to non-alcoholic fatty liver disease in an epidemic circumstance, and with these kinds of outcomes, it's unthinkable. I put this model for the explanation for non-alcoholic fatty liver disease. I realize that it's not very sophisticated by comparison with a lot of the things that we've heard today, but simple ideas are possibly easier to hold in one's head. The basis of deposition of fat in the liver is to do with free fatty acid supply based on insulin resistance, obesity, dyslipidemia, and there is an implication that bile acids control dyslipidemia, and I'll come to that. There are secondary hits of pro-inflammatory pathways resulting in cytokines and a contribution from the gut-liver axis resulting in NASH from NAFLD with oxidative stress, a secondary phenomenon from fat in the liver. The genetics play a part. We've touched on this already at some length, but I would just like to mention some of them. And I think the important ones, as you know, are PNPLA3, But it seems that the more variance a person has, the more likely they are probably to accumulate fat in the liver. The children appear to be, and as far as we have information, similar in their genetic etiology to adults. And many of these genes are similar to alcoholic liver disease. So not surprisingly, there's an overlap between the two, and not surprisingly, that may make a confusion in diagnosis. There's also the environmental considerations, including lifestyle, diet, exercise, and weight, and I'll try and touch on those, although I have to say our impact on lifestyle from where we are as a specialist centre is not that strong. Again, we can talk about what are the dietary components, and we can debate them because they're not clear, but high energy intake is certainly important. More saturated fat possibly, trans fats, although I know that the European Union is removing trans fats from foods steadily, lower rate of polyunsaturated fatty acids, high cholesterol intake. All of these have evidence behind them, but they're not absolutely the case for any one of them. There are some uncertain factors. Total calorie intake perhaps matters less than excessive calorie intake and weight increase. The role of protein, I think, is very unclear. Omega-6 fatty acids and their pro-inflammatory effect, possibly. And then the question is, can you combat that with antioxidants? It's not clear. I'd like to talk now a little bit about what we do. We acknowledge that fatty liver disease, or NAFLD, is a diagnosis of exclusion. So by the time the patients come to us, it's our job to make sure there's nothing more serious going, and although this is serious enough, going on behind the scenes. Our protocol is based on ESPGHAN, European Society of Pediatric Gastroenterology, Hepatology and Nutrition guidelines. And they're often the features we've described to you about those of metabolic syndrome, even in children. There's often a family history of complications of metabolic syndrome, including type 2 diabetes in about 40%, but other things like early stroke, early heart attack, etc. It's important to exclude other treatable causes, and for us, the one on the top of the list is probably Wilson disease, because it does look just like NAFLD in children, in adolescents. Whereas in most pediatric disease, you're usually dealing with only one diagnosis, which is great. But this is a circumstance where more than one diagnosis may be present, and one has to be very cautious of that. The last speaker dealt extremely elegantly with metabolic causes in the context of non-obese NASH. This is a list which comes from Pietro Vairo in Rome, which is the ESPGHAN guidelines to think about these genetic or syndromic causes, rare hereditary causes, and drugs and hepatotoxicity. I don't want to go through these in detail, but certainly they are part of our job as a specialist unit to consider all these and exclude them. The other one I would like to draw attention to, apart from Wilson disease, is glycogen storage disease, because there are some mild GSDs that, again, look like fatty liver disease, or NAFLD. So, following a local workup with anthropometry, we hope, social and dietary history, and I think it's worth getting a social and dietary history locally as well as from us, because there may be differences, and I think closer to home is a better place to get this kind of information. And then referral to our specialist clinic, where we have a specific dietetic review and make recommendations from that. We try to provide lifestyle modification or recommend it locally, but even that's currently a problem. We can discuss that probably. We investigate for insulin resistance, and we following that, if necessary or if indicated, we may perform a further oral glucose tolerance test, particularly if the first one's marginal and the patient's put on more weight. Bariatric surgery can be offered and occasionally has been. So the first-line investigations based on that are listed here: height, weight, etc., etc. Lactate as a rough marker of glycogen storage disease, lysosomal acid lipase, which was referred to by the last speaker and very helpfully, And then we have second-line investigations, including liver biopsy, and I'll talk about our selection of liver biopsy in a moment, a metabolic screen based on the previous slide, and then we have some research ongoing. This is how many patients we're typically seeing. So this was data from 2015, 2016. It's even more than that now. So we typically see 150, then 175, over 200 patients now with fatty liver disease per year. And we're seeing over 400 visits. So it's quite a significant proportion of our work. I mentioned the numbers of new patients last year. They're mostly seen in outpatients, but there are some day case investigations, particularly for glucose tolerance test. Most patients have come from a pediatrician rather than primary care. And interestingly, a significant proportion claim to have, or say they have, abdominal pain. Now, I'm not clear whether abdominal pain is a feature of this condition, or once you're referred to a hepatologist with a worry about your liver, it draws attention to the fact that it may hurt. But certainly 73% described abdominal pain. I don't believe anyone else has suggested that that is found with this. Ultrasound has steatosis in 41%, but abnormal liver tests also in 45% by the time they get to us. There are many coexisting conditions which are associated with fatty liver disease, which we found in our series, and 38 or nearly 40% have already evidence of type 2 diabetes. These are the investigation, whether or not we managed to achieve them, and mostly we did, except for waist circumference, which we're not good at recording. And I think that's because we don't regard it as that reliable in children, particularly the smaller ones. Ultrasound results are shown here, and so you can see that steatosis was seen marked in about a third, moderate in about half, and none in just a minority. And splenomegaly on ultrasound in nearly half, suggesting that they have got some degree of progressive liver disease already. 62% of our patients who came to us and didn't have diabetes or evidence of diabetes already had abnormal glucose tolerance, and one was already diabetic. This is the rate of follow-up. Typically, patients are seen 3 monthly to 6 monthly, but some others, for other reasons, more or less frequently. Our management consists of visiting the fatty liver disease clinic, mostly, as I say, 3 to 6 monthly, with dietetic input. Some decline dietetic input, but most of them have a focused, personalized plan. We try to provide alternative lifestyle support, including an app and Slimming World, but these, I think, it's difficult to monitor how well they're adhered to. Those who have evidence of diabetes are either already on metformin or we start metformin. Unfortunately, it's not always that well tolerated, and 2 patients had bariatric surgery. I won't go into this in detail, but this is the algorithm from the ESPGHAN guidelines as to whether or not you should do a liver biopsy. And you can work through it if you like, but I think it's better to summarize it like this. Our indications for liver biopsy are persistently abnormal transaminases, persistent splenomegaly, the suspicion of severe disease, and the suspicion of an alternative diagnosis, particularly those lean patients. Non-alcoholic fatty liver disease histology has already been described and typically looks like fat with some inflammation and variable degrees of fibrosis, and is more often in adults described as type 1. On the other hand, in pediatric practice, we more often see type 2 non-alcoholic fatty liver disease or more NASH with perhaps more fat, but more importantly, more inflammation and more fibrosis. And 2/3 of our patients already had F2 fibrosis by the time we biopsied them. I don't know if that's because they're progressing more quickly or if it's because we are more hesitant to biopsy them. So there are some differences between adults and children. There's the question of antenatal priming, the liver as a store of fat in an obesogenic environment in utero, or those, as already been referred to earlier, as the predisposition of an obese mother to have a genetically obese child or epigenetically obese child. Children are highest consumers of fructose and sweets. There is a tendency for the pediatric liver or the maturing liver to have more ductular reaction. Our type 2 pattern seen in 2/3, as I say, implies a more severe disease, but how to interpret that, we're not quite sure. But it's fair to say that by the time they get to us, they already have, in large number, significant ongoing liver disease. And here it is in summary. Steatosis is severe in the biggest group on liver biopsy for the 71 we did. Inflammation mild, but bridging fibrosis F3 in the biggest group. So in summary, over 175 children followed up at our unit. 2/3 are actually attend the non-alcoholic fatty liver disease clinic. Others overflow into other clinics. The study protocol or the follow-up protocol is mostly adhered to, but we've not been very good at getting abdominal circumference and sometimes the full OGTT as opposed to just a fasting insulin was missed. A liver biopsy in 41% and bridging fibrosis in 40%. High incidence of insulin resistance and the numbers of referrals are increasing all the time. We have good dietetic support, but lack of wider MDT support. And unfortunately in the UK, local and community resources are very unfocused, disorganized in terms of managing this kind of condition. Treatment options, I think it's worth saying that apart from giving dietary management and metformin to those who are diabetic, at the moment we are not doing anything, and we can talk about that. This is the tonic trial. You may well be familiar with it, and it was a comparison of metformin, vitamin E, and placebo in children, and showed that actually vitamin E was the best, both in terms of improving transaminases and improving liver histology. It's suggested in the NICE guidance that vitamin E should be administered based on an ELF test. The problems of getting an ELF test in the UK have already been alluded to today. So we tried to, because it's expensive, we tried to develop our own ELF test based on biomarkers. And
unfortunately, we couldn't put together anything which sufficiently accurately predicted our own histological findings. So we haven't gone any further with that at the present time. The ELF test, is, including in pediatrics, is supposed to indicate that vitamin E should be administered with mild ongoing liver disease and then discontinued with severe fibrosis. We don't do that. There's also the possibility of modifying the disease with intestinal microbiota, and again, some reference to that has already been made today. The information that I've noted is to do with intestinal microbiota being changed or having an influence on appetite, weight gain, and insulin sensitivity, as well as liver chronic inflammation. There are a number of studies, including some done by Pietro Vairo from Rome, looking at changes in ultrasound and changes in transaminases, and positively so. The problem is that the numbers are small, and it's difficult to know whether this really changes the natural history of the disease in the long term. There's also the Flint Trial. I imagine that many of you are familiar with this, but the features which are worth drawing attention to is that 72 weeks of obeticholic acid given against a control group improved ALT, AST, gamma GT, and had 2 kilograms of relative weight loss compared with the control group. And in addition, there was histological improvements, which are summarized here. The problem is that patients didn't tolerate this very well, particularly with respect to severe itch. It's possible to modify this condition in the community regarding it as a public health issue, which I think it is. This is a study from Leeds, where locally an intervention in modifying diet and exercise from reception, before reception classes at school, working with parents, particularly mothers, and focusing, at least in part, on deprived areas. And the outcomes that are summarized here, you can see that the Leeds group are in green. UK data from contemporaneously is in orange, and the neighbouring towns, Bradford and the like, in the northeast of England are in blue. And you can see that there is improvement overall, but the biggest improvement was in the most deprived areas, showing that obesity can be modified by changes in parenting style supported by local services. Another similar piece of information is the Amsterdam Healthy Weight Programme, where a more intensive and citywide healthy choice program was implemented, so that eradicating overweight and obesity was regarded as something that the city must do as a public health issue over a generation. Everything which was planned should be things which were easy to do and be supported, and people should have direction and tuition in what they needed to do. In other words, it was a learning by doing approach. And this also appears to have a very good effect on reducing obesity in that area. So I think there's good evidence that obesity in children is something which needs attention from early childhood, and it's a public health problem. So thank you very much for your attention. I've put this in because this is the kind of diet which ultimately I think we're all going to be aiming for. More vegetarian options, less meat, less fat, less fructose, and Gwyneth Paltrow got there first. Thank you very much.